Welcome back to the Fracture Files, the silver linings of geriatric fracture care. My name is Megan Sorich. I am a orthopedic surgeon that specializes in geriatric fractures at UT Southwestern in Dallas. And today is Dr. Carmen Quatman.
Yeah, good morning. I'm Carmen Quatman. I'm also an orthopedic trauma surgeon who focuses on geriatric opportunities for better care. And I work at the Ohio State University Medical Center. Thanks for having me.
So today we're going to talk about what happens after you get discharged from the hospital with a hip fracture.
Yeah, I think it's a great topic. I think we focused on a previous one about the first 7 days, but that's just the very small amount of time that we as providers in the hospital get a chance to work with the patients, and so much of the outcome depends on the minute they discharge, and even some of the planning that we do while they're in the hospital, so that they don't only have a safe discharge but a safe plan to move forward and guide them through the recovery process.
So I have a question for you. We sometimes have trouble with follow-up, post-operative follow-up for our hip fracture patients. Are there some strategies to help mitigate that you guys do that seem to be successful?
Yeah, I think that's a great question, and maybe we can take a little bit step back and unpack the idea of discharge planning and where that gets put in the chart and communicated to the patient. I think the hardest thing is that most of these patients have different disposition plans. Sometimes it's to a skilled nursing facility. I would say probably about 70 to 80% of the time to some type of rehabilitation or skilled nursing facility. And how that plays out can really impact their ability to get back to follow-up care. The second part of that is if patients go home and making sure that they're ready to go home safely so that they don't end up bouncing back to the hospital or having difficulty even getting transportation to a follow-up visit. And then the other part of this is that I think that we just have a huge bottleneck in information dissemination. So even if we let the patient and or family know that they need follow-up and that we even schedule it ahead of time, there's just so many barriers to that follow-up that can come up that are not really strategically planned for. And there's a lot of things happening on at the discharge time period, so that's not taking the highest priority in their mindset. It's things like, how am I going to get safely home? What is the transportation home going to look like? And so thinking 2 to 4 weeks out from that time frame can be very difficult. So when I think of strategies for our own team, the communication is critical, that it goes in the chart before they discharge. So previously it used to be like have the family or the patient call to schedule follow-up, and you can imagine what type of follow through happens with that. So they get discharged with a huge packet of information. The chances of even from a typical human behavior standpoint, being able to make that action happen can be difficult. So I think first and foremost, planning way ahead of time about the critical next follow-up, communicating that and communicating multiple times in multiple ways is really important. I think that the other piece of this is if they go to a nursing facility is making sure that there's a commitment from that nursing facility to make sure that they get their follow-up. But that being said, if you go back and look at your no-shows in clinic, most of them tend to be people who have gone to nursing facilities, and that comes down to a lot of different barriers. The first one often being, did they have the transportation set up to make sure that they can get there? The second being, is there a commitment on the nursing facility to make it happen? They may not have any true incentives to make sure that they make a follow-up, and they'll try to find every way possible to not make that happen. So I've seen with the uptick of telehealth, we had a lot of people convert as many as they could to telehealth, which I will say for most of our patients, and Megan, I'm sure you can claim this, if there's even a little bit of a cognitive barrier, it's not a good follow-up period, regardless if you do telehealth. And that's complicated with COVID, for example, keeping them safe and making sure that they don't miss their activities in their nursing facility too. But there's just so many barriers that go into that not follow-up period. And I think if there's a paper our team put out about the timing of complications after hip fracture. I can't recall the journal, but it was a couple years ago. And what was really fascinating in that is we kind of broke down the day-to-day timing of when most complications are set to occur. And it's really that 10 to 14 day time frame. And so it's such a critical window of catching things where we're missing it. So So it's kind of a loaded question you asked me there, because I think that there's a lot of barriers that have to be understood. And there's a lot of things that need to be figured out at the individual level to make sure that it can happen. But I will add one last thing, which is there's nothing more frustrating when a patient with cognitive impairment shows up with a packet of information dropped off by a transport service, and they're asked to navigate how to find the office, get x-rays, and somehow communicate care back to the nursing facility about what the next steps are. And I can't imagine a worst case scenario than having that happen. So
You're totally right. And I really like your point about really engaging the family, if there's family available, just to help with the commitment for their loved one's post-operative fracture care. That's a really valuable point. And I like the idea of even trying to do that before they leave the hospital. And then even if they do end up with a telehealth, even talking to the family just to create kind of those engagements that maybe while they're still in the skilled rehab facility, but when they get discharged, talking about safe discharge, and then really kind of engaging the family member. Those are excellent points.
So, what are some of the strategies you guys have tried to mitigate that loss of follow-up?
So similar. So we do schedule a follow-up, at least on the books, post-operatively. And then if that follow-up is missed, not only do we call the patient, we call the family. If we know what rehab facility the patient has gone discharged to, we'll try to engage that rehab facility as well. But I do think our capture rate for hip fracture follow-up is probably about 50%, which is a little bit higher than the national average, but it's definitely something we struggle with. And you're totally right. I feel like it happens more often when patients go to skilled rehab facilities.
Yeah, yeah. So if they do miss a follow-up, what do you do? Do you guys track that they missed the follow-up and try to get them rescheduled? Do you leave it up to the facility to?
Exactly. No, we get them rescheduled and then again engaging the facility, uh continuous phone calls not only to the facility but the family member. More often the post-operative visit is missed while they're in the facility, but after they get discharged, usually then we can recapture that patient. Um and again, I don't know if it's, to your point, if it's a transport issue, if it's a communication issue. That's something that I think we don't always know why that first post-operative visit is missed. Um, but
Yeah.
the patients that I think are most vulnerable are the patients without good family support. Those are the ones that not only do we miss their first post-op, but we usually miss most of their follow-ups because it's hard to create that engagement, especially with our patients with cognitive impairments.
Yeah. I think it's an interesting thing to think about for that 2-week follow-up, or kind of that around that time frame, about, what are our goals at that time? And I think a lot of it really looks at capturing, the mobility that they're starting to have or not have. And if they're not having it, making sure that that's emphasized. But a lot of it's about taking out staples or stitches and checking the wound. And I think some of that can be handled by telehealth, um, or at least good communication with the facilities. And so one of the things we've acknowledged, that if they can't make it to that 2-week follow-up, and for whatever insurmountable barrier, sometimes we have opportunity to go on site. We have credentialing to go to some of the nursing facilities around us. But if we can't go on site and do that, or we can't get that telehealth communication, I think making sure that 6 to 8 week time frame definitely has a follow-up can be really critical to their care. Most people would say, I don't get x-rays in 2 weeks most of the time, especially if we did an arthroplasty, because I feel like at that point we're going to know that they have had a complication, and it does decrease the time in the waiting room and things like that. So we're able to kind of facilitate it unless there's any major concerns. We rarely get an x-ray at 2 weeks. But I think that that 6 to 8 week time period of getting an x-ray can be really critical to understand where things are headed and going. And I think not necessarily even for a hemi arthroplasty, because again, I just need one follow-up x-ray for that most of the time to feel confident that we're doing okay. But the bigger thing for me is at this time point is where they often have transitioned home and they feel miserable and that they should be doing better. But the truth is many of them are doing way better than they think they are. And so just
Very
setting the goal,
true.
just making sure we set the goals and expectations at that time point for them to understand if, yes, you might not have been using a walker before, but most people are still using a walker. But look at you, you're out of this nursing facility, you're starting to get your independence back. We're on the right track. Sometimes they come in and they're not even using anything and they're still feeling miserable. Like they're like, I feel like I'm not back to myself yet. And it's just to me a window of like that 8 week mark seems to be a real mental frustration for patients and this kind of loss of independence, and it's coming to a reality for them. And so I almost feel like it's more of a counseling visit than anything, and it's actually more critical to me than the second week visit.
Yeah, I agree with you. I think there was a paper that came maybe out of University of Minnesota about the value of postoperative x-rays in hemiarthroplasty patients. So you're totally right. That helps decrease time in the waiting room. That their paper said that it's not that needed and it's not cost effective. And again, you usually know when they're not doing well. You don't need an x-ray to tell that. And I think that's an excellent point. Similar to your second postoperative visit, I call that my encouragement visit or my cheerleading visit, that we talk a lot about that you are doing better than you think. And then we talk a lot about the fear of falling. So once they have a big fall, that's a huge psychological barrier that it's challenging for patients to overcome, that they're afraid of going out on the sidewalk where they had that first fall, or they're afraid of the bathroom in the middle of the night where the event happened. So talking to get over some of that mental block is, I think, super valuable. You're totally right.
Yeah, that's a great point. I think the fear of falling, encouraging that's normal. I mean, there's a trauma component to this, right? So they had an abrupt change in their life and their lifestyle related to this, and that fear of it happening again is a very real fear. So while we don't often have the opportunity or even ability to get counseling, there is a true trauma response, an acute trauma response to it that I think is completely underexplored. And so I do find ways to try to give them courage and understanding about where their new adaptations are. And we are very fortunate to have a falls clinic for referral to, although a lot of them are still too acute to be able to go to that. I encourage them that if they continue to get strong, we can send them to the falls clinic to work on some of their other concerns. And I think that can't be underestimated. And I think if we had a geriatrician on with us right now, they would emphasize the other parts of this. Like you and I are focused on the fracture and the fracture healing, but there's just so much more that goes into the fact that why did they have that hip fracture in the first place? What were some of the things that should have been on the radar ahead of time, but this fracture just alerted us to more, those type of things. So, this from an orthopedic surgery's perspective, I think our time is so limited, and I wish we had more time with them because that cheerleading visit is so critical. And it's often where I start to have that conversation about making sure their PCP, their primary care stuff is set up, making sure that I don't think we're going to dive in today, but bone health conversations around trying to prevent that second fracture. So even though it's only a simple quote unquote follow up on my schedule for the day, I acknowledge that it's not a 15-minute visit sometimes, and sometimes it's like 20, 25 minutes. Sometimes I'm looking at their gait aids, like were they given the right ones at discharge? Are they trying to be too aggressive or not aggressive enough? I watch them walk. I watch how cautious they walk or not walk, and we talk about that sometimes. So I think it's just a really critical visit that's not reimbursed well, and so it tends to be a very secondary thought process, whereas we need to really start to engage opportunities for our other services and teams that are available to talk about that, how critical that time frame is.
Yeah, I agree with you. I feel like another thing that I usually talk about at that visit is the perceived loss of independence. That whether if they're still living with a family member when they used to be independent, or if they're still at some type of a rehab facility, or maybe at this point, families talking about moving mom or dad into a a different facility. This is usually that conversation that we have about, hey, this is temporary. This isn't a permanent kind of mobility issue, that you will continue to improve. But you might still have a cane, a walker, or something like that to help you ambulate. But I feel like the perceived loss of independence is something that we really highlight at this visit, and talk about that this is again a temporary situation.
Yeah, totally agree how critical that is. Um, Beyond that 8 week mark, do you bring them back for another follow-up? What do you tend to
I
strategize?
do. So my time frame is usually 3 weeks post-op, because 2 weeks usually they're still at some type of a rehab facility. So I found that 3 weeks is kind of that sweet spot, that usually I'm getting more patients to come back to the clinic, and then a month after that, and then usually a month or 6 weeks, depending on how they're progressing with therapy, how well they're ambulating, all that kind of stuff. So I do kind of keep a close eye on them, especially within that 90-day post-operative window. But after that, I feel like it's a little bit variable based on their progress. If they're still struggling a little bit with physical therapy and I want to keep an eye on them, I keep on seeing them for either 6 weeks, 2 months, that kind of stuff. How about yourself?
Yeah, I would say the majority after the 8 week mark, I try to use a feel for how they feel personally and the independence that they have. So for example, here in the Midwest, we do have a pretty aggressive winter sometimes. So I will usually schedule them out for their like a third visit essentially, or a follow-up at that kind of um 3 month, 4 month mark. But I usually tell them it's really up to them if they feel like they need to make it. And certainly if there's a winter weather issue that they should call to reschedule, or we can convert to telehealth, because um, I just don't want them getting hurt in the parking lot. And it's a really silly thing, but to them, that I've seen people show up on the worst of days because they think they have to be there. So I try to just give them the flexibility of needs. I do have concerns sometimes if I, for example, did an intramedullary nail and I'm watching for healing. If it was a really tough fracture, or they had a more difficult fracture pattern, I will often schedule them and ask them to make sure that they come up. But if that winter weather problem happens, to make sure we reschedule. So I try to, it becomes more individualized. I'm surprised how many people want the social visit again, and that's great. But I like to give them the freedom to do what feels best to them, if I can.
Yeah, I like that. And I feel like most of the time I'll even say, you're doing so great. You're really graduating. We'll schedule an appointment, but if you're doing great, you could just call me, or we could have a telehealth, or and then 9 times out of 10 they come anyway to be like, look how great I'm doing. And I kind of, those are probably my favorite
Yeah.
visits.
Yeah, and I will say I definitely have the very frail elderly patient who this is a huge ask for them to come to follow up. So we have a lot of conversations about what are the real goals and expectations. If this truly was a palliative treatment, then I often will offer them to say, I know you have a lot of other doctor's appointments going on, like just keep me on the radar if you need anything. So I try to really be mindful of what stage they are, and what their ultimate goals were. And that's, I think, empowering back to them and the family.
Yeah, those are awesome suggestions. I love that.
Well, any other thoughts that you want to bring up for this, like the next 7 days?
I think that on the horizon, some things that we will be talking about is emphasizing bone health, emphasizing getting reconnected with their geriatrician or primary care doctor. These are all topics that we'll probably explore a little bit more in more detail, but I think it's definitely worth re-mentioning. Absolutely.
That's awesome. I think the most important thing I'd love to really dive down into is how to make your home safe for that next transition. So maybe we can explore that in future dates.
Yeah, that would be a great topic. I feel like, again, usually a lot of the falls do happen at one's home, and some of that is not intuitive and can be scary. So yeah, that's a great idea.
Awesome. Well, great to chat again. I really appreciate it.
All right. Well, thanks so much for joining us for another great adventure of the fracture files, the silver linings of geriatric fracture care.